Well, good afternoon, everyone. It's a pleasure to have you guys join us on this snowy and icy Friday afternoon for our next Friday seminar series event. And as you've heard, if you've been in the last several sessions, we're very excited this semester to put a greater emphasis on interprofessional education. And we had a very successful and fun The Mask Profession event a few weeks ago, where we had an opportunity to talk more about what it is that some of our specialties do and don't do, so we can get to know each other a little bit better. And now today we're going to have the first of a two-part series where we're actually going to do a deeper dive into a case project that we're going to do together, and then have a case competition among our students and our faculty, where we are all going to have to work together to solve a public health issue. So with that in mind, I'm going to turn things over to Dr. Jenny Stolo. Jenny is going to go ahead and lead our competition. Dr. Jen Ibrahim and Dr. Sue Scanlon and I have been planning on this event all spring, and then we just happened to find out that Dr. Stolo actually has a great deal of experience running these competitions. And so she's going to give us an overview of what we're going to be doing, and then she's going to turn things over to our guest speaker for the day. So Dr. Stolo?
Great, thank you. Hi, everyone. This is going to be a great session, and this is a great opportunity. So I'm just going to really quickly tell you about this inaugural College of Public Health Interprofessional Education Case Competition. Basically a case competition, right? For those of you who don't know me, it's good to see familiar faces, but for those of you who don't know me, I am an assistant professor here in the Social and Behavioral Sciences Department, and I work with the World Health Organization, CDC, and a lot of different partners as the Global Outbreak Alert and Response Network, RISCOMS, and Community Engagement Focal Point. What that means is that when there's an outbreak or an epidemic or a pandemic, they send in the big guns. Kidding, I have very tiny guns, but this is a great opportunity for you to put your heads together and think through, how are we actually responding to things like COVID-19 in Philly? So are you with me? Yes. So here's how it's going to work. We're launching this really great opportunity for y'all to get some applied experience in cross-cutting public health issues. We have students from all different departments, different specialties, different disciplines. So let's mix y'all up and figure out what you can do. So here's what you actually need to know. This is just going to take place in the month of March. This is for graduate students and doctoral students. A sign-up link, I think we could put it in the chat today. It's also going to go out on Monday. What will happen is that starting March 1st, I'll mix y'all up into different groups with different departments and different backgrounds, and you'll work as a team to figure out a solution to Philly's COVID-19 problem. Now, it's just a 5-minute video pitch and a 2-page proposal. Pretty straightforward. And I know you're sitting there thinking, why do I want to do more work? Well, first of all, this isn't work. This is just a really good time. Second of all, here are some benefits for you. The first is that all of the projects are going to be featured during the Temple College of Public Health Research and Evidence-Based Practice Day. That's one bonus. Another is that select projects will also be featured in the National Public Health Week social media. And to top it all off, the top 3 projects are going to be sent directly to the Philadelphia Department of Public Health. It does not get more applied than that, right? Actually taking steps towards solutions. That's what public health is about. So throughout the month, we can work together, we can brainstorm, we can troubleshoot. It's going to be a really, really good time. This is going to look great on your resume, right? And for a lot of you master students in a field course, you need to do this. So if you need more information, if you're interested in this at all, let's do it. Let's put our heads together and help everyone in our backyard. I'll send it back over to you, Jen.
Great, thank you so much, Jenny. And we will be sending out information. I'll be putting it in the chat shortly, but you'll also see a follow-up email that will be coming out later this afternoon. So if you didn't get that, also look for the email that will be coming out, which is going to be a really good opportunity for all of us to come together. So thank you so much, Jenny. So now I'm very excited to welcome a new friend that I made in the midst of the pandemic. We're very fortunate to welcome he goes by Fred, Dr. William Pilkington, who has quite a bit of experience in public health. He has over 4 decades of experience in public health. And this morning or this afternoon, he's going to speak with us about a little bit of reality and a little bit of simulation. So being able to walk through some of what they experienced in Urbania, as you've seen in the case study that went out, but really giving an opportunity for us to analyze and to really think about what has happened over the last several months at the federal, at the state, and at the local level. And then this case competition is a way for you to springboard and to reflect on the conversations that we'll have today, and then move into thinking about how are we going to move forward? Where are there opportunities for us to rethink the way we've done things in the past, how to be more innovative? What are ways that we may be able to bring more disciplines together to bear to increase the workforce capacity that we have in the event of a future pandemic? So with that, I would like to give the applause and thank you in advance so much, Dr. Pilkington, for being with us. And I will hand it over to you.
Thank you, Jen. And thank you for asking me to do this. And I'm very excited about today. And I hope that we all learned something, especially me, as we've been engrossed in COVID-19 now for a year, it seems. I take a couple of perspectives in the way I look at this, and one of them is to look at it from this perspective of a local public health director. As Jen said, I retired last year with 39 years as a public health director in Cabarrus County, North Carolina, which is about 22 miles north of Charlotte. As I like to say, I got out just in time, but it was interesting in that because they didn't have a director, they kept pulling me back in since I continued to live in the community. So I was in the midst of it. Hence the reason why it has the unique title of Urbania County, because I kept getting involved in several counties around the Charlotte area, which is where I live, with COVID-19 issues. This public health problem and public health issue interested me because I kept asking the question, who's leading this effort? And I think all of us can agree, just fill in the blank. It could be depending on a community, depending on the nation, depending on the day, who was in charge. It has been interesting throughout the process. The context is leadership and how it affected the pandemic response. I almost call this case the curious case of COVID-19 in the United States, kind of taking off from the Benjamin Button analogy. But it has been a bit strange in the way that I have experienced public health issues over 40 years and the way that it was handled. A little bit of background on me so you have some idea of where I'm coming from. It's always good to know what someone is thinking when they talk to you about things like this. My education, interestingly enough, is all in public administration. I had one public health course in my entire life, and that was epidemiology, which I still regret. So it was an interesting course. And I have taught a lot in schools of public health throughout the nation, but I have not really ever had a good educational background in public health. I have a master's in public administration, a doctorate in public administration, and most recently I went back to school a few years ago at my advanced age at the Naval Postgraduate School in Monterey, California at the Center for Homeland Defense and Security. I went because one of my old dissertation chair actually runs the program, and it is very devoid of any public health folks being involved. Most public health people are not engaged in the program. It's usually FBI, Secret Service, Homeland Security. In fact, I was in the program with one of your local PD folks from your fusion center, a gentleman named Jay Bowen, who's with the Philadelphia PD. But it's a great program. If you're interested as a public health person, it's completely free. It's about a $90,000 education paid for by the federal government. And Monterey's not a bad place to have to spend some time. My work experience, as I said, has all been, I've only had 3 jobs in my life. And almost 40 years. One was as the Cabarrus County Public Health Director. The other two jobs were also in healthcare. I was the healthcare advisor to the governor as my first job out of graduate school. And then I went to work as in what was called a health planning agency for 3 years after that, before moving to the health department. What I'm going to do today is talk a little bit about the process we're going to go through so that you'll understand and have a chance to have input. I don't want to be the one talking all the time, so I want you to be asking questions and challenging some of my assumptions, which are, as I've said earlier, my assumptions as a public health director. So I'm doing the case summary first, so just an overall summary of the case itself, which all of you have had a chance to look at and read. We'll go through a little bit of a PowerPoint with some key pivotal questions, which I think are important to stimulate our thinking. And then finally, Jen's going to moderate and look at your questions in the chat box and pull together and try to assimilate them. And I'm going to pause at certain points throughout the PowerPoint presentation for you to discuss those questions. And so we can have a little bit of that, I think, good, fruitful discussion. Interesting enough, this whole case study in my mind began a year ago, almost to the day. It was on Valentine's Day that I was in Washington, D.C. with several other local public health directors, and we were discussing how to improve accreditation through the Public Health Accreditation Board for local public health departments. All day long, we were starting to get a lot of information and text and news flashes about the coronavirus and what was going on. The consensus, though, at the end of the day, when we were through and all heading back to our homes, was this was just another SARS virus out of China, not much to worry about. Little do we know how wrong we are or were. What we did know at that time and what we didn't know is critically important, I think, when you began at this point. We knew that we had a virus originating out of Wuhan, China. We knew it was spreading rapidly in at least two continents, Asia and Europe. We also knew that the World Health Organization had declared a public health emergency. And unfortunately, we also knew that CDC was experiencing some startup glitches in terms of testing, faulty testing kits, and responding to requests for help from local hospitals and public health officials. What we didn't know is how infectious this virus was and the fatality implications. We didn't know the total number of cases we had confirmed worldwide. We also didn't know how the first case in the United States was exposed, which was important to do tracking and follow-up. In Europe, we started seeing cases growing rapidly and deaths in Italy, and then over to Spain. We also were alerted early on that this may have been in different countries much earlier than we thought, maybe even as far back as the fall. In the United States, we soon moved to the top. In March and April, we moved to the top in cases and the top in deaths, and have stayed there since the coronavirus began. We went through a series nationwide of lockdowns, school closures, our economy was decimated. So the impact was pretty widespread throughout all of our lives, as all of you know. The case then moves on and talks about the structure of public health in the United States and public health federalism. Public health federalism is not a term that a lot of people talk about or understand, but public health federalism is based on the fact that we have a federalism form of government where decisions primarily go down to the local level. And in public health, it's quite like that, in that 33 of our 50 states have public health departments, which are at the local level pretty much autonomous. In North Carolina, where I work, there are 85 health departments out of 100 counties, and every single one of those health departments basically makes its own decisions. The state health director cannot instruct those local health departments in anything that they are doing other than providing money and restricting flow of money that comes down from the federal government. Now, in contrast, to take a state like Florida, where the Florida Surgeon General is directly over all of the local health directors, and they report directly to that health director, that's an entirely different statewide system. And you see the same thing in Virginia as well, and some other states like Tennessee and South Carolina. we had a history of poorly funded public health in this country. We also had problems in our surveillance systems early on with COVID-19 and how we were reporting cases. There was not a consistent established way. It was state by state, again, territory by territory. So we had some early issues in recognizing how serious the spread was and how fast it was occurring in our country. Next, the case study looks at the North Carolina experience at the state and local level. And it begins with the first death. The first death actually occurred in our county. It was a gentleman heading back from Mardi Gras who stopped here at our local hospital because he was feeling too sick to drive. And he was COVID-19 positive and he died in the hospital while he was here. So that's how it initiated in North Carolina. The interesting thing about North Carolina is as we moved into the same pattern as most states like Pennsylvania and others and saw a lot more cases, we started seeing the lockdowns that everyone has experienced as the immediate response. And we started to see the political and politics part of the coronavirus epidemic rear its head. North Carolina was unique in that we had the Republican National Convention scheduled for Charlotte. We also have a Democrat as our governor and a heavily Republican legislature in both houses. A lot of pressure, a lot of emphasis on not locking down, not closing down, making sure that Republican convention occurred. As many of you probably read in your national news publications, the president was very adamant about that convention going through and with all full attendance and so on. And that didn't happen. What we also saw during this in North Carolina, and I'm not sure what you saw in Pennsylvania, but public health leaders were not leading the effort. The effort was being led by politicians, primarily and elected officials. And the context of that is it's an election year, of course. So within that election year, decisions were being made that were somewhat reflective more of the politics of the situation than the science of what was going on. We had issues around emergency declarations and face mask and on and on. Emergency declarations were declared in county by county, but I got involved myself in a lot of those emergency declarations and kind of on a consulting basis. And it was really difficult to convince local elected leaders facing an election to declare the emergency and then to enforce it and use their DAs and other people in their counties to actually prosecute people who violated the rules and requirements. So that was a big part of it as well. Initial efforts by most of the elected officials and public health focused on not creating any panic. So the public health emergency declarations were always tried to be handled as don't be concerned. This is not something that we're just doing this for protection right now. We don't expect this to be a huge problem in our communities. Again, remember, this is all early on. We also saw inability to ramp up and get testing going in our state and to meet testing demands. There was just not, public health was just not in a financial position with its resources to do that. The growth of cases and deaths, especially in historically marginalized populations, soon became a problem and became something of a need for public health to step forward and address. In my particular area, we saw 2 early forced resignations of local public health directors because of their adamant response to needing to put science first, and that created problems for them. Nationwide right now, we've seen almost 200 public health directors lose their jobs and for factors related to COVID. So very much an issue at that level. The next part of the case study looks at COVID-19 in election year and primarily focuses on things like misleading, inconsistent information from public health and the media, and how the delegation of response was down to the local level for lockdowns and reopenings. As you saw, that primarily became not a national effort, not a state effort, but a local effort. The new normal is the next part of the case study, looking at the fact that we now have one of the top 5 leading causes of death in the United States going to be COVID-19 for 2020 when all the data finally comes in. And the fact that we're now moved to a point where we have social distancing and face masks pretty common, used throughout our country. And the promise of a vaccine, which in the case study ended in August, so the promise of the vaccine was still coming at that point in time. Final part of the case study deals with public health at the crossroads. At a national level, as I said earlier, we had CDC not showing good leadership, not showing the effectiveness that it has in past epidemics and problems in our country with infectious diseases. We had testing failures. We had supply chain issues and getting PPE and other needed equipment to our healthcare providers, which related to questions about the whole viability of public health as the entity to which could respond to something of the nature of a COVID-19 pandemic. So with that, I'm going to stop, Jen, and move into the slideshow, unless there's something that anybody wants to comment or discuss before we do that. Jen, are there anything you want to bring up?
Nope, there's no questions in the chat right now.
Okay.
So if you want to move into the slides, that's perfect.
Excellent. So as I said earlier, I thought about calling this a different title, but came up with Navigating in the Dark, Leading Public Health Through COVID-19. And a lot of that based on talking with my colleagues, not only here in North Carolina, but throughout the nation. As having been a health director for almost 40 years, you know people everywhere at some point. And listening to them talk, having phone conversations with them, everybody was asking essentially, where are we looking for direction? Where's the direction coming from? And still wondering when the direction would come. It wasn't coming necessarily from the feds, wasn't coming from the states. Local elected officials, as I said earlier, were concerned and worried about causing problems if they did too much. So all those things put public health in kind of a unique situation of having to deal with that. The lenses that I looked at this through were 3 lenses. You can probably look at it through a variety of them. The ones I looked at it through was a policy, political lens, an economic lens, and a social lens, primarily focusing on the policy and political lens. The science lens would have been a nice one in addition to add, but that's not one of the ones I reflected on in the case study as much because science got diminished so much during this past year as part of the policy decision-making process. So the goals of the case study were to explain why COVID-19 was different. Early on in the outbreak, I heard a lot of my colleagues say, this is, as I said earlier, that February meeting, this is no different than what we've had before. Why do we need to get all excited about it? So there was a little bit of a reluctance and an inability to get geared up and get going. And that was very different. That's what this case study tries to look at, why it was a different thing and why we needed to be treating it much differently. Also to analyze it in comparison to previous pandemics and their responses. We haven't had anything like this in my 40 years. The closest thing would be the AIDS epidemic and the way that it came about and was handled in the country, but doesn't provide the same kind of analysis because it was a different disease and the way it was spreading around the world was different as well. So this is, and its economic impact was not as significant. So that was also important to analyze. And finally, to look at how the US responded and the strategies to address the pandemic, which is what I'm interested in your response to as well, because there's a variety of things we could have done and didn't do. This is the setting for the analysis. This is a map of North Carolina, and this is the area I live in. I actually live right here, and this is the area I'm primarily talking about in the case study. This is the research triangle where Duke and Chapel Hill and the University of North Carolina are, and this is our coastal area, mountain area over here. So we've got 100 counties, and we have 85 local health departments, which is pretty amazing in terms of states. So let's begin before the pandemic, which is important to look at. I think all of us probably thought we were pretty well set up to handle almost anything. We just handled an Ebola scare fairly easily. So we should be okay. But if any of you have watched Bill Gates do his TED Talk, you would probably go, no, we weren't. Most of us in public health were of that position. I reflect back that to this day, we're still telling people we can handle a smallpox outbreak if one occurred, in which we have 72 hours to vaccinate the entire population, or look at probably somewhere in the neighborhood of 50% of the folks that contract smallpox dying. I think we found out really quickly that we can't vaccinate within 72 hours. That's even though we've been preaching that and telling people that. Interestingly enough, the Global Security Index in 2019 ranked the US first among 195 scored nations to handle a pandemic. And those were based on criterions of prevention, detection and reporting, rapid response, the healthcare system itself, our compliance with international norms, and our risk environment. Interesting. So let's move on to the early stages of the pandemic and where we were. As I said earlier, 1st of February, we were starting to see a few deaths. We started to see the first American death in Wuhan. We started to see the first American case shortly thereafter in the United States. Global deaths at this time were not very many compared to looking at the current data. 813, 12 people confirmed. But we already knew a growing problem. Some of the questions I raised in the case study around this time that still perplex me and make me wonder what we were doing from a public health perspective relate around to how much the scientific community knew and how much the government knew about the potential deadly impact of this pandemic. I think many of you heard our president on television say that he didn't want to panic the population, but he knew how impactful this pandemic was going to be, but played that down. And when was that information made available to the general public? Did we make that information available as soon as we could in the right ways and to the right kinds of publics? And we have different publics in the US, especially historically marginalized populations. And how do we get information to all of these groups and get them aware of the impending literally disaster that was coming toward us? Secondly, I ask and wonder, did the World Health Organization err in its evaluation of the pandemic? And were there any other motives in that evaluation? Our president raised questions about that. Other politicians and policymakers have raised questions about that. For months, we did not fund the World Health Organization, and President Biden has decided to fund the organization, has come back with a change in that. But it still leaves errors about the World Health or questions about the World Health Organization and its role during that time. Third, how prepared was the CDC for this pandemic? Clearly, with the faulty test kits that went out initially and the response to some of our providers asking for help, healthcare providers, there were some problems. Were there problems significant enough for CDC to be as diminished as it was in its role during this time? I'm not sure. In my 40 years of being a public health officer, CDC had always led every effort, been the primary spokesman, been the primary counselor to the policymakers. But in this case, you saw Dr. Fauci and Deborah Birx as the people who were speaking for the public health community, but neither of those were the Centers for Disease Control. Whether that's right or wrong or the best, I am not sure. And finally, as I just showed you on the previous slide, how did the most prepared nation in the world fail so miserably in responding to COVID-19? There's a lot of arguments about this as well. Did we fail miserably? Well, when you look at the fact that we have, I think it's 4% of the world's population, but 25% of the cases, clearly, and we've had that since last spring. there's certainly some problems. With that, I'll stop, and again, I give you a chance to have some discussion, or Jen to look and see if there's anything that people want to discuss, because I've raised some impactful questions.
So being a panel, I can indulge some of the questions that I have too. So can you say just a little bit more, the comment that you made with regards to the misalignment, I would characterize it as, the CDC typically leading the way in this sort of instance, but having Dr. Fauci and Dr. Birx leading. How do you think that played out in terms of any confusion or a lack of confidence from the general public that there was this sort of infighting between these entities within the federal government?
I think it caused confusion in both the public health community as well as the general public. We had always been counseled, told, and religiously listened to the CDC. And essentially the CDC went silent. And whether it was for political reasons or not, I'm not sure, because I'm not party to the discussions that were made on that. But suddenly when Dr. Fauci was the leading spokesperson on this, that had not occurred in the past. And I think that caused some of that in addition to some of the things that occurred afterwards, where the CDC would write guidelines for what we needed to do in terms of social distancing or school closures and so on. And those things would be revised, I guess is the best terminology, by the past administration. All gave us, and I think it gave the public mixed signals. When the CDC came out itself and said we didn't need to wear a mask, after they had said we did need to wear a mask, I think the public got really confused at that point, and that created issues for those of us in public health trying to communicate and give accurate communications, because essentially the word among public health folks in those days, around here anyway, was whatever they say today, they'll change tomorrow. And you can imagine if the public health leaders are feeling like that, what is the rest of the country thinking? And I'm sure some of you had the same concerns, that too many times, too much of the things that were being said were changed, questioned, or completely revised. And so that created all kinds of problems.
So we have a couple questions coming in. So one attendee asked the question with regards to public health being underfunded. Do you think that there will be more sources for public health moving forward?
I would certainly hope so. I am concerned that if we don't do a better job with vaccinations than we're doing at the current time, that what we will see, and I address this in the case study at the end, is a call for a different structure for public health. Hospitals have stepped in and done a lot of traditional public health work during COVID-19 with outreach, with vaccinations, with testing. All those things in the past were public health responsibilities and in the purview of public health. The hospitals and other entities that stepped up and did this testing, a lot of private companies were doing it, have done a great job. And I'm sure at least people at the policymaking level questioning, does the public health system have a delivery system to handle a pandemic? And if not, what should we create? So I think that's a concern. I'd like to see more funding, but there is a ton of money coming down through this different stimulus packages, including the newest one for public health. But the question is, will it just be fleeting money? A lot of money came to public health right after 9/11, and it was gone within 5 years. So I think that's very much a concern, whether or not we will build systems and infrastructures that can handle what I call surge level, as well as the day-to-day public health problems. Always traditionally, public health has been responsible for handling whatever happens that day. And we've done a pretty good job of it. But this was an overwhelming situation. And I have looked at a lot of my colleagues recently, actually getting both of my vaccinations for COVID. And I felt so sorry for them. They looked exhausted. They're out there vaccinating 10 hours a day. And there's no additional help. There's no into this. And now we're talking about the fact that there's a possibility that vaccinations may not last beyond 3 or 4 months, and that we have to start off with a whole set of boosters again. And I'm sure those people are going, no, I can't handle that. So there's a lot of concerns out there.
And just on that note, I will give a shout out to our nursing faculty, our nursing students, and all of our volunteers who have been helping with our vaccination clinic for folks at Temple and also for the North Philadelphia community. So I'll give a shout out to them because I'm sure they're tired too.
Yes.
I want to acknowledge the question. There's a question on public health infrastructure. I'm going to hold that because Dr. Pilkington does have additional remarks, so I'll hold that question till the end. There was another question, how would you, or where would you say the US ranks on that index? So you showed the index a slide ago. How would you say the US would be positioned post handling of COVID-19? So that index was from 2019, but post, if you were going to rank us now, where would you say we are?
I would say we'd fall somewhere down below the top 10, probably. I mean, you've seen the results worldwide where countries like South Korea have done an excellent job. Germany's done an excellent job in this area. Even though they're all having issues like we are, they've done a better job of contact tracing, done a better job of following up on cases. The problem we have in this country from a public health standpoint is, unlike the United Kingdom, the Prime Minister there can tell every single public health official what they're going to be doing, and the entire National Health Service. That can't happen in the United States. And because of that, I've always held a concern, what happens if we have a major disaster? This is not a man-made disaster. It's a disease disaster, but what would happen if we would have something on the scale of 100 9/11s at one time? How do we respond to things like that with the smallpox virus being launched in the middle of them? We don't have an organized effort. In North Carolina, just to give you an example, when we have frequent hurricanes, when we have a hurricane, the state health director will call the local health departments and say, can you send me a nurse? Can you send me this? And most of the health departments say no. They're not going to send anybody. They don't need to send anybody. They're not state employees, on and on. We need a system where we can call everybody up. I've argued that we need something similar to the U.S. Public Health Service that would be nationwide, and everybody on that would be on call and disposable to the president in a disaster like this. But we don't have that. So I'd say we're down on we'll be down on the rankings the next time they come out, especially based on our response.
So if you don't mind indulging, and Jenny, I'm going to put you on the spot. I just texted her and gave her a 2-second heads up. Jenny, I know you're doing work with the WHO. Can you just touch on that from the global perspective, if you don't mind?
Happy to. So thank you for all of the questions in the chat. Keep them coming. This is a super complex pandemic that we're dealing with right now. And it's really interesting. Thank you, Fred, for bringing up that measure, that matrix, because it's really interesting what we're seeing as well. The US and a lot of Western type global North type countries were marked as most prepared or most likely to succeed in these situations. We are actually seeing the opposite, right? So we're seeing that countries who scored lower, I mean, was it a good score or not? This was a good test of it, right? Because if you look to countries that have experience with contact tracing, with infectious disease outbreaks, et cetera, they actually have been handling it better for reasons of cultural norms around disease prevention or background in training and contact tracing, right? A lot of times in WHO, we think that we need to deploy people to go help with Ebola outbreaks. But for COVID, a lot of people in the African continent, Asian continent, were trying to get to the US to help because people felt so bad about the humanitarian health issues happening here. So just to give you a little bit of perspective of kind of how we're really changing the way the US is viewed in terms of global health and what we can learn from others. Thank you.
Cool, thank you, Jenny. Fred, another set of questions that are coming up are around vaccinations. And so I'm gonna pull two questions together and you can answer as you choose. So one question is, with vaccinations, what are your thoughts in terms of, the public health approach addressing the historic distrust that we see in some communities around vaccinations? And I'll throw in also your thoughts if there's any shift here with the anti-vax movement, and also situations where we will have various reasons for medical exemptions. And then the other piece of it is, what are your thoughts around paying? If we do not have commercial payers not looking to reimburse for this, what are your thoughts in terms of being able to move forward with the level of vaccination that we need?
Well, that's a complex question.
It's my curveball coming at you.
It's interesting enough, and I should have covered this. I stayed retired for one day. In North Carolina, we have a university, North Carolina Central University, which is a historically Black college and university. And they came to me and asked me, based on my experience in working in racial disparities in healthcare, would I work for them? After 6 no's, they finally tucked me into it. So I began working in that area. As soon as COVID occurred, we established what we call the Advanced Center for COVID-related Disparities, known as COVID-related disparities, known as ACCORD. And we did testing and surveying of thousands of people at testing sites throughout North Carolina. We found very early on, back in the spring last year, that historically marginalized populations weren't being tested. Sites were not being offered in those neighborhoods. They were not being offered where they were accessible, available, or acceptable to those neighborhoods. And acceptability is a key part of it as well when you're looking at cultural sensitivity. We also started surveying and asking questions as the fall moved along, or the summer moved along, about the possibility of a vaccine, because you remember in August, we started hearing the vaccines were in test trials and it looked pretty good that we'd have them by the beginning of the next year. So we asked questions about vaccinations and we found a lot of distrust, as you might imagine. About 62% of our historically marginalized populations, and that's both Native American, or more than both, Native American, Latinx, and African American, said they would not get a vaccine. Interestingly enough, we charted that from the period of August until January, which is our last surveys we tabulated. The numbers went down to 32%. And it's almost a direct straight curve down. And the acceptance rate goes straight up and intersects somewhere about November, interestingly enough. What we heard a lot during the fall was, as long as this administration was in power, there would be no vaccine that they would trust. And so the vaccination acceptance rate started going up after the election to some extent, but it really took off when we started seeing the efficacy of the new vaccines, the Pfizer and the Moderna vaccines. When both of those started showing 90% plus efficacy, we started seeing huge increases in every population except the Latinx population. That they just still stay high in distrust of the coronavirus vaccine. What I think we need to do in these areas is we haven't done a good job educating and communicating historically marginalized populations about the vaccine. We haven't catered the messages the way we need to those populations. And we're working on that at the university where I work and doing a lot of messaging work, core messaging center we've developed to do that. And we've been spending a lot of time working with religious groups and community organizations who represent historically marginalized populations, trying to be factual as clearly as possible and as culturally sensitive possible, as well as recruiting from all these communities we work in, what we call community facilitators, who are people trusted in historically marginalized populations to help us spread that word, to work on our behalf to convince their neighbors and their friends that the vaccination effort is important. In the midst of all this, you have, as Jen just said, the anti-vaxxers and the other problems that relate to historical mistrust in historically marginalized populations with Tuskegee and other issues. We still have not done an adequate job of addressing those. I was on a call last Saturday with a group of religious folks, bishops around the state of North Carolina, and the African American Church's organization there. And one of the bishops said, and this was interesting, he said, I have a 1% chance of catching a virus for which the vaccine is 90% effective. You haven't done a good job communicating risk to me. And that hit me real quickly. I thought I had done a great job communicating risk, but he made the point, and I went back and we started working on some materials then to look at how we communicate risk and how we explain risk. So I think, Jen, there's a huge and massive number of issues out there that we don't understand. And a lot of the times it's because we don't listen and to communicate. We spend all of our time in public health talking and very little time listening. So I'm hoping we're changing some of that. I'm going to move on to this. It's okay to go and move to the next slide.
Sure, that's totally fine. I was just going to say, and with regards to the center, I just put the link in the chat for folks who are interested in learning more about the center and the work that they're doing.
Oh, thank you. Next, we're going to move to the spring. I think most of us by this time are thinking this is just going to be over by the summer and we'll all be good. I know I was not one of those people, but I was one of those people who heard that a lot. I was also hearing at this point in time that it's not real. It's not even a real disease, that people are dying of something else and we're just making this up. But by this time, we were in the midst of it. As you all know, we were the most infected nation in the world, and the cases were growing exponentially as well as the deaths. So the pivotal questions for me at this point in time is, what were the critical decision points that might have averted the loss of hundreds of thousands of American lives? You probably saw projections saying we probably wouldn't have more than 50,000 deaths. Worst case scenario was 100,000. I think Dr. Fauci himself said 150,000 was his projection at that time. As you all know, we're getting ready to hit 500,000, and the numbers will keep growing, hopefully not as exponentially as they have over the last couple of months. So I wonder if there were decisions that we could have made at that time that would have been critical in changing that dynamic. I think the other thing that concerns me and it makes me want to ask is, what could our leaders in the healthcare system have done to try to influence decision making? Because every time you saw someone, especially at a local level, step up, they became a scapegoat. People were concerned about their jobs. They were concerned about things other than the number of cases and the impact of cases. You saw people like the Ohio Public Health Director with people on her lawn threatening her life, and she resigned the next morning. So I wonder what we could have done differently and how we could have acted during that time that would have made a change. So I'll turn it over to you, Jen, if there's some questions coming in on that.
Sure. And earlier when you had mentioned that point, and as you're talking, I'm trying to share some of these resources with everyone, but I had put one of the articles in the chat with regards to the number of public health leaders who have resigned. And there's 2 links within that website that also talk about the harassment, the threats, etc. And I will give a shout out to Annie Frankel and Lori Friedman, and I have been working on a study looking at burnout in public health practitioners, and social workers, and that being a really significant concern, that we're dealing with these challenges, and how far can you push people before our public health practitioners are just to the point of being beyond what they can handle. So we have a couple more questions. Again, following up with the vaccine, there was a question. One question that's in the chat was, there's a study from Canada that 1-dose vaccine is almost effective as 2-dose vaccine, as 2 doses of the vaccine. What are your thoughts there? And again, I think just re-emphasizing that question, not just the financial piece, but you raised the issue of how long there's conferred immunity and the potential for having boosters. And what are your thoughts, if that is the case, how do we expand our capacity? I ask that in part because on the call today, we have folks from physical therapy, occupational therapy, athletic training, speech language, social work. We have as I like to very lovingly call it, an army of health professionals within our college. What are your thoughts if we have to move in that direction to expand our public health workforce and to think more innovatively?
I think one of our missed opportunities here was when we talked about a potential for a smallpox, we talked about anyone who could use a needle, basically giving the smallpox shot. We've just now geared up the pharmacies, just now geared up the dentists and other folks, even veterinarians, people who can give shot, anyone who give a shot. Put it in every place you can put it. It doesn't have to be. One of the concerns I've had is all these centralized locations and large mass vaccination sites are good for getting numbers, but are they good for access and reach of populations? The corner store, the beauty shop, those kinds of things are places where I see us being able to give vaccinations and do a better job. So I think we need to increase the availability of vaccinations and the accessibility of those vaccinations. I think at the same time, we're going to have to keep, at some point in time, they're not going to be paid for, as you mentioned earlier. And if insurance is not going to pay for them, how much is that going to do, again, to creating disproportionate cases in disadvantaged populations? What's going to happen then? And we have a deplorable history in this country in that area in terms of making healthcare a right or a privilege. And is it going to come down to that in COVID? Are we going to end up with, someone asked me this morning when I was in the dental office, what's going to happen in the future? And I said, I think what the future looks like is next fall, we're looking at the same thing we look at in flu. Instead of 50,000 cases, it'll probably be 75 to 100,000 cases of COVID each year. We'll lose a certain number of people from those, or 50,000 deaths, I should say, not cases. We'll lose that kind of numbers in COVID-19. We'll have boosters on a regular basis, just like we do for the flu. And we'll all go about our normal business knowing that's the cost of this coronavirus as it continues to grow and stay within our population. But it's going to be tough to figure out the ways that we can be innovative within the system that we have.
So one question as a follow-up to the point that you made in conversation with the meeting with the bishops, someone said they're curious to know what is the message. So you gave the example of the bishop saying to you, I have 1% of a chance of catching something with a vaccine that's only 90% effective. What would your response be to that person?
Well, my response to him was, you have 4 times the chance of dying as other segments of the population. And if you are the one person infected, then with that kind of risk, then you're certainly putting your health in jeopardy. Which he still responded, he didn't understand that risk. So what we have tried to do is go back and start segmenting out risk factors that affect historically marginalized populations based on activities that they do, for example, essential workers. So yeah, you may have, if I'm a person who sits at home all day and does nothing, then I don't have any chance of getting COVID. I'm not going anywhere. But if I'm out there driving a bus in New York City or Philadelphia, then I'm being exposed to people all the time getting off and on my bus. And we have a number of cases of those kinds of essential workers who died. So I think we have to do a better job of finding out what these populations that we're concerned about are doing on a day-to-day basis, seeing what kind of incidents of COVID-19 has occurred in those populations and what kind of fatality rates we've had. And then we can say to them, yeah, if you're a minister, as he was, and you're not holding church except virtually and you're staying home, you're good. But the moment you start going to the hospital and visiting your sick parishioners, you got a problem. And puts him almost in the same category as anyone else out in the public life. So I think that's one of the messages we're trying to work on and develop.
Great. Okay, so if we want to keep going, I'm going to hold some of these questions just because I want to make sure that there's an opportunity to get through the rest of the slides. Okay,
I'll go on to the summer. And we all know where we were in the summer. The cases were, as you can see from the nationwide COVID metrics on the right, daily cases and daily testing all going up throughout the summer. Makes me want to ask these questions. Was the devastating impact of COVID-19 a US healthcare system problem, which is something we just talked about in the answers to the questions I was giving, or a science problem? Was our science not there? Some of you know the UK has a system called SAGE, and SAGE advises the Prime Minister about science issues related to COVID-19. We don't have something similar to that, and we don't have that kind of scientific input into our COVID-19 decision-making system as yet, as far as I know. President Biden may be making that happen, but it didn't happen during the first 8 months or so of our outbreak. Also makes me wonder if public health federalism is viable in an era of deadly viruses. Can we continue to allow 50 states, all the territories, and local governments to make decisions about how we each handle the virus? When you look at Florida, for example, where Disney World is open, and California, where Disneyland is closed, what does that say about our ability to handle a public health problem? And clearly, the numbers show that we're not handling. Third, what other options were not explored that might have changed the course of COVID-19 in the US? And what could we have done if we had explored those courses of action? Some people have argued we should have done what Sweden did and just left everything open and continued down that road. Sweden did pretty well with that, but if you've seen, they're now considering a lockdown. So their numbers are getting much worse. Were there other things we could have done in terms of vaccine acceleration and gotten a vaccine out quicker? I don't know that we could have, but what are those options? So I'll stop with that and let you ask some questions about it.
Sure. So one of the questions that we have, I'm interested in how public health infrastructure is checked, how frequently, and what would alert the public health infrastructure to a potential problem. So I think going a little bit off of what you just said with regards to SAGE, and can you also say a little bit, we have some folks on with us today from informatics and health information management, about where you think there might have been a different strategy, a different approach in terms of our centralization of data and information with regards to the pandemic?
Well, we have two primary ways of alerting local public health officials in our country to problems. One is the EpiX system and the other is the HAN system, Health Alert Network. EpiX is a system that operates on the basis of, say your local public health director in Philadelphia sees something that they think is a legitimate problem. They can post that on EpiX. It gets vetted by experts at CDC and posted so that people like those in North Carolina or other states can see there's an outbreak of X going on in Philadelphia. We need to look at that. And it alerts you. It's a secure system. It alerts you on your phone, on your tablet or your computer. So you get it fairly quickly and you get alerted for these kinds of things. The other thing we have is the Health Alert Network. The Health Alert Network is based on confirmed cases. So once something is confirmed, then it's spread out nationwide to everybody at that point in time. They didn't go silent, but those networks were not as active during COVID-19 as they were during other outbreaks and other problems, even foodborne outbreaks, for example. So I think one of the things we could change in terms of a course going forward is making sure that that kind of information related to COVID-19 is shared quickly. We also need to share it consistently. As I said earlier, we don't have consistent ways of reporting information. In North Carolina, we have communicable disease cards, literally cards that are mailed from doctors' offices. And now we pick up on emergency rooms. So if you showed up in an emergency room in any of our hospitals, our public health surveillance system picks you up. But if you go to your doctor's office and something is not as common as COVID-19 and you get a diagnosis, it could take two to 3 days before your local public health official sees that. Is that significant? Well, yeah, it is significant if we're trying to stay on top of an outbreak. And so we need to know if it's spreading, how it's affecting schools, all kinds of things. So we have a real problem in this country. I spent a great deal of time when I was at the Naval Postgraduate School working on a project for the Department of Homeland Security on how we could do a 12-hour alert system, so that anytime we had, basically a red alert, anytime we had something going on within 10 categories, fevers, headaches, nausea, so on, top 10 factors, how could those be rapidly fed into a system by physicians and hospitals and emergency rooms and urgent care centers? And that data kicked out that afternoon, and immediately alerts go out that in community X, something is going on. And we don't have that kind of system. And we were working very hard using text messaging and other things to read signals that, what we called hidden signals. That was the title of the project, to identify infectious diseases.
So one other question that came in that I think speaks a little bit to a range of issues that you've talked about is, one of the challenges that we face, whether it's with government officials or the general population, is folks' understanding of public health. And so the question that came in was, when do you think we should start teaching about public health? And I guess I would add on to that is, do you think that there's a role for teaching? You see sitcoms and everybody talks about there's the health talk when the boys go here and the girls go here, but do you think there's a need within education that we should be doing some form of basic public health education?
Definitely, I think so. I mean, when I was at the Naval Postgraduate School, I was the only public health person in the program, and usually they have one in every master's class they have there, but it's not necessarily limited to one. It's usually only one that applies. So although public health is considered one of the critical sectors of the Homeland Defense Security enterprise, it's not emphasized there. There's not a course in public health. There will be soon, but there's not any recognition that public health can be as damaging or as impactful as 9/11 was, for example. We spent a great deal of our time learning about terrorism and terrorism theories and man-made disasters, white supremacists, on and on, infiltrating different organizations. So that was a great deal of the emphasis. And I think that was because, as you mentioned earlier, Jen, we haven't done a good job in public health of educating. I spent all my time in public health. First question I would ask when I spoke to any group was, how many of you have ever used the public health department? And you would see maybe one hand in a room go up at the most. And I would say, oh, the rest of you don't eat in restaurants, I guess. And they would go, what? They would not understand that we inspect all their restaurants and all of them eat out, or we inspect the school. We actually inspect the sanitation of the hospital in our state. So we impact them in many ways. I think we've got to do a better job, because what we did, and all of you in public health know this listening to this talk, but we did such a great job of eliminating what were considered the childhood diseases, and then tuberculosis and other things that were problems, that basically we went away. Everybody said they've done such a good job, they don't need to be funded anymore. And then things like multi-drug resistant TB reared their heads, and people said, well, maybe give them a little money here or there. AIDS came along, maybe a little money here or there. And then when public health preparedness popped up after 9/11, maybe a little money there, but they as policymakers and as a public in general don't understand that it is significant. I've heard so many people in the last couple of months say, wow, I didn't know public health could do all this. And yeah, we can do it, but with limitations, with the kind of money we have.
Mm-hmm. Great. So that's it for questions that we have right now. We'll keep going with the slides, but again, for anyone, if you have questions, please add them into the Q&A box.
And remember, this case study ends in September. I'll probably follow up with a second case study after this, but this is about the time that the elections were coming toward us. Our governor in this state, for example, was a Democrat up for election, won a very tight election. We elected a Republican senator. We overwhelmingly voted for Donald Trump. And so we were in a situation where in a state like ours, it was almost political suicide to recommend that you take very aggressive actions against the pandemic. Science was not in the forefront. What our legislature said over and over again is they were tired of hearing about science. Makes me want to ask again these pivotal questions. Will the United States be more prepared for a similar pandemic in the future? Again, if you haven't watched Bill Gates' TED Talk, watch it. It's really powerful. And you will have another pandemic, I assure you. It may not be in the near future, but it could be in 2 years, as far as we know.
I put it in the chat for everybody. Yep, I think that's a great resource.
Do we continue to delegate final decision-making responsibility to 50 states and the U.S. territories? Can we survive as a people if we continue to handle public health in this way? And can the U.S. political system handle science in its decision-making to create evidence-based policies, or will it always be predominantly a political decision? The dangers and advantages of handling pandemics in a federalist system of government. What changes might help us respond more effectively to future pandemics? What can we do about the way we structure our government? Could that change anything? So that I'll open up to questions.
So Fred, on that first point, can you talk a little bit more about FEMA? So here in Philadelphia, just maybe an hour or two before this talk started, there was an announcement that FEMA will be coming into the city and running the mass vaccination clinic at our convention center. Can you talk a little bit about the role of FEMA in relation to this response, where they could have come in, where they should have come in?
Sure. The vast resources of FEMA, again, primarily handling natural disasters, is where their expertise comes in, but they are quite expert at logistics, bringing supplies together. They work closely with people like Walmart and other companies that know how to move goods fast and get them to locations. I've understood that from dealing with hurricanes and other events. Surprisingly enough, they weren't asked to be involved as well as I can understand. And it's only within the last few weeks that FEMA has become a player in the vaccination efforts. They also have strong, they have a large workforce. They have strong connections to local communities. In many cases, they can bring to bear a lot of personnel to do things like arrange vaccinations, get vaccinations done, acquire sites, set up places that vaccinations can be done. I know that one of the things we've dealt with in our state is testing, and vaccination sites have been hard to come by. A lot of these are going on outside in drive-through clinics in very bad weather. I know you guys are having terrible weather up there now, but we've had in the 30s and rain for 5 days, and we've been conducting vaccination clinics. I don't know if any of you feel like that. I wouldn't want to be standing in the pouring rain for 36 degrees giving vaccinations, and we have not been able to locate good sites to do that. One of the sites here was the Charlotte Motor Speedway, which is where the NASCAR races occur, and that's in our county, and they actually gave people the option to ride one lap around the track if they got a vaccination, which was pretty popular, interestingly enough. And it was done in the pit area, which was a shielded area, which was a great place. It's a racetrack that handles about 160,000 people, so it's a huge place. So those kinds of places do exist, but primarily, like our local hospital here was doing it with these metal covered tent kind of things, which were exposed on all sides. And they're just not good operations. So FEMA can they can bring supplies about, they can bring shelters about, all kinds of things. And I'm not really sure why FEMA wasn't more involved and asked to be involved before this point.
You talked about the different levels within government, but can you share your thoughts on moving forward greater opportunities for public-private partnerships, and where there could be potential for better response, faster response, more innovative response? I think of the world that we live in terms of technology. I saw something on the news last night that it was a small little device that I think was being made at Penn that is a way to detect, and I don't know the legitimacy of this, but the technology is what intrigued me, that it was a device to be able to detect COVID-19 that they're testing right now, plugging into your phone. So what are your thoughts on public-private partnerships?
I think they work well, and we need to do more of them. As I said earlier, FEMA did a good job working with Walmart and folks like that on how do you get supplies quickly. If you've probably seen in a situation like a hurricane, the place that has supplies the next day is Lowe's, Home Depot, and Walmart. They have all the supplies they need. And we've not ever figured out how to emulate that and copy that. And FEMA finally tapped into those resources and did it. In terms of vaccinations, one of the things that was done in this area around here is we looked at Chick-fil-A and how they were serving drive-thrus and how their strategy was being used, and it works perfectly. How you get a large number of people through in a hurry through different registration, or in their case, online system, and a flow that works, pull aside for separate things. All those things were important. So there's lots of things there's lots of learning we can do. Why didn't we pull in the pharmacies sooner? That everybody comes in for a prescription. I'm not sure why we didn't have them vaccinated quicker and earlier in the process, and how we made those decisions. I mean, there's some serious questions about why Publix, for example, got vaccinated before anyone else, and some you can read online and see some of the questions that have been raised about that. But why didn't we make decisions about allocating vaccine around areas of need, problems of concern, willing partners, especially in the private sector, as opposed to contributions to political parties and such? Those kinds of things should not have been the ways that different vaccinators got ahead of others.
Mm-hmm. And I put the link to Chick-fil-A in the chat. That was one thing I thought that was just so interesting. I think it was on a Saturday morning that I heard it, and I sort of did a double take, and then I had to look up the story that, yeah, I mean, sometimes we can get a little bit too big for our britches, that we know the right way to do things, and sometimes looking to other industries with a different lens is really the ideal way to be thinking about it. Any other questions? I know some folks had to leave for other meetings and classes at 2:15, but I'll put one more call out there for any other questions that folks wanted to put into the chat box. I'll give it just a second, and then otherwise, Fred, I will give you the opportunity for last word, any closing remarks.
Just a closing remark, and I know you'll appreciate this, Jen, but I think you mentioned it earlier about public health. It is in a great sense of missionary work. Those of you who are going into public health and going to be in allied public health professions know this. It's very important work. It makes a huge difference every day in people's lives. And especially in this pandemic, we've got to pull a public health system together that works nationwide and do everything we can to make that happen. Mm-hmm.
And I think that's a perfect way to wrap this up. I think that's one of the things that we're trying to do with opportunities that we are trying to host, such as this one, for all of us, students, staff, and faculty, to be thinking more from an interdisciplinary perspective and thinking about the ways, where are there places that we are not located, that public health is not. And, you know, one of the places I think of is in the school systems. Once upon a time, there were school nurses in schools, and now we don't see that. But Jamie Mansell, our director of our athletic training program, knows we've got athletic trainers in schools. And so is that a place that we can be taking this public health lens? Where do we have social workers who have contact in the community, and they can be carrying a public health message? So it's sort of almost counterintuitive, I think, sometimes to be generous and share our public health mission more broadly. But I think, to your point, if we're really going to get to an effective public health system that is nationwide, that there's better coordination. I look to my informatics colleagues that we've got a better system of integrating the epidemiology and the surveillance that we have with distribution and dissemination of that information for evidence-based policymaking. I think you're completely right. I think we have to, I don't want to say knock down the system and restart, but I think we need some serious consideration of how we can be innovative and move beyond the past. So I see one more question. Okay, Rosalind, you get the final question. What advice would you give to public health students today and moving forward from this?
I was hoping I'd get to answer that question.
Good.
I would say go into public health first of all. Last time I looked at the numbers, Jen, and you probably looked at them more recently than I, about 80% of the local public health workforce had never taken a course in public health. So kind of like me. So go into public health first of all. I know a lot of you want to work for hospitals and healthcare systems and in other jobs, but I will tell you from 40 years of doing it, there is no job more rewarding than public health. I always tell the story. We started a dental clinic early in my career, and there was a young man who had never smiled because he had such bad teeth, and our dentist, over several visits, created a beautiful smile for him. And that young boy lived in the neighborhood that our office was in, and I had a window right on the front of the building, and he would come by and bang on my window and smile at me every time I went by. And that made my day every single day that he came and did that. That's the feeling you get from public health every day. You make a difference in someone's life. You make no one money, including yourself, but you do create a huge difference in the lives of other people. So go into public health, give it your best. And most importantly, I can say this to you, that you don't be your job, do whatever needs to be done. Because the thing I'm seeing a lot in young folks now is, that's not in my job. Well, it's not a job that's specified and clarified in every case. It's whatever needs to be done to help the public.
And I think that's a great point to end on. It's really a mindset and it's a passion.
Yes.
Excellent. So please join me, Dr. Pilkington. Thank you so much. We really, really appreciate this for the case study itself and then spending time with us today. So David, I will turn it back to you.
So that was a fantastic start to this two-session series. So Dr. Pilkington, thank you very much. And I found the discussion and commentary very, very engaging. I have one last announcement, which I've been asked to share with all of you. As many of you likely heard, there's been a lot of movement just in the last day or two around increasing vaccination availability in the city. So obviously we just heard a little bit about FEMA coming into the convention center, but I would encourage all of you still on the call. The Leah Corris Center is currently open for the next 24 hours and is being staffed by the Black Doctors COVID-19 Consortium, hosting a vaccine clinic for individuals who are in category 1B, which is now a little bit more relaxed than persons who were eligible for vaccines just a few days ago. So if you do know anybody who lives in the North Philadelphia community who is interested in getting vaccinated, there's a walk-in clinic, no appointments necessary, in the Leah Corris Center, open as of noon today, all the way through noon tomorrow. So if people can navigate those icy sidewalks and streets and can get there to be vaccinated, I think that's a wonderful opportunity. Again, no appointments necessary. People who live in the zip codes around our main campus are welcome to just walk on over and get a vaccine within the next 24 hours. So please spread the word as best you can. Otherwise, I look forward to seeing all of you again next Friday as we continue our fall series and continue to work on these great cases. So take care, everybody, and enjoy the snow.